Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
So let's talk about treatment, and then I'm going to hand over to Marc shortly. So the first thing of treatment is every person who has HAE needs to have acute therapy. They should be using it as early as possible and for every attack. And there's just been some good studies showing that people got treated within the first hour, they do much better than if they wait after an hour. If they wait 8 hours, and some of the old literature suggests 6 hours, it probably doesn't do them too much good. So we always say, if you're having an attack, treat yourself. Don't wait till hours to when it becomes severe and then use your medication, because it may not be effective at that time. So earlier the treatment, the better. Everybody needs to have rescue, no matter if they're on prophylaxis or not. Further to the right, short-term prophylaxis, everybody needs that too. That needs to be a discussion with your patient. I like to have backup therapy, which would be IV plasma-derived C1 inhibitor or recombinant C1 inhibitor available in case they need a procedure, especially an emergency procedure. And then lastly, if you asked me many years ago, I'd say only about 25% of my patients were on prophylaxis, but now it's about 75%. And that's because to the far right, you can see on shared decision-making, every time I see a patient, I talk about long-term prophylaxis, and Marc will talk about that a lot more in the next minutes here. So the ultimate treatment goal for HAE, I think, is to have people normalized. Normal means not having symptoms of HAE. It means, to me, complete control of the disease is not having attacks. That's not always possible, but I can tell you with the new therapies and those therapies that are coming up, I've had quite a few people who have gone 3, 4, 5 years without an attack, who used to have 3, 4 attacks per month. So it is possible in most cases to achieve control. If you can't achieve control, you want to make that person as comfortable as they can, have the fewest attacks they can, so they can maintain a normal life. So for the next interactive question, which patients with HAE should have rescue therapy for HAE attacks? A, those who are not on long-term prophylaxis. B, those who have more than an attack per month of HAE. C, all HAE patients. And D, shared decision-making should be used to determine who needs rescue therapy. Hopefully, the majority of people would have got this question correctly, and it's all HAE patients. So those on long-term prophylaxis still have a possibility of having an attack. So you would not want for a person not to have rescue medication. In fact, we worry about, like food allergy, that people may not be carrying their rescue medication who are well controlled. Those that have more than one attack per month, well, they need the rescue medication, but so does someone who's only having one attack a year, right? Because that attack could be of the upper airway. And that's one reason why I look at all children, whether they started having attacks or not, should be tested. And if they're tested, they should have rescue medication, because their first attack could be of the upper airway or a GI attack and lead to unnecessary surgery. And then, so the answer would be all HAE patients should have rescue medication. Marc, do you have any comment on that?
No, I think I would just emphasize what you said. As preventative medicines get better, people sort of forget that they could still have breakthrough attacks. None of the preventative drugs are perfect. So it's really important we remind them that they keep one of these effective medicines you're going to talk about available at all times.
Okay. So these are the therapies we have available. So we have ecallantide for acute treatment. Now, most people would say there's little place for it because it has to be given by a healthcare provider. But, I still have a handful of people on it, mainly those people who say don't have a family structure and the kids actually sit in the house with their attacks and don't get brought to the emergency room. In this case, they can get ecallantide, have a nurse go to the house and get it administered by the nurse. The reason why it can't be given by the patient themselves, it has a risk of 3 or 4% of anaphylaxis. Mark, have you been using any calitide still, or is this a medication because the anaphylaxis you totally avoid?
No, we use it occasionally for certain patients, but it's not utilized as much as the others here.
Okay. And then we have icatibant. Now, about 97% of people will have a significant reaction at the injection site. It doesn't prevent people from coming back usually, though, because it does work. It's down to 18 years of age in the United States. In Europe, it's down to 2. We've been fortunate that in our hospital system, we can get it down to 2 years of age. So that's worked out very well, as we'll talk about when I get to the case, which is next here. There's also plasma-derived C1 inhibitor. This works very well. It's the best drug for short-term prophylaxis. The problem is it's IV, and that does limit its ability to be given, especially at home, especially a parent to a child. In the past, we had everybody was trained how to use IV injections. And now, since the prophylactic agents are really sub-Q, people are losing their talent at that. And then lastly, we have recombinant. This also requires an intravenous injection, which adds to the burden of the drug. The nice thing about replacement C1 inhibitor, though, it shuts down all the pathways that C1 inhibitor deficiency is activated. So I don't know, Mark, your use of therapies, similar icatibant, because it's generic and because it's sub-Q and self-administered, mainly what you're using for treatment of acute events now?
Yeah, frequently. But as you kind of mentioned, or we see, there's some variability in response to drugs occasionally. So again, we'll talk about it a little bit later, but individualizing care and making sure that the drug is working and well tolerated by a patient. We do have to change the treatment plan occasionally for those issues.
Mm-hmm. No, I agree too. And I have some young, especially females, who you have a BMI that's minimal, who would rather give an IV injection than a sub-Q injection because it's so easy for them to access their veins. So let's look at this patient. So this is a kind of a sad patient in many ways because, again, of poor family structure. Her mother had HAE, abandoned the kids. And so she had HAE for years. She didn't have attacks, but then she started having attacks. We tried IV C1 inhibitor, which is actually indicated for her age group. Her access, though, was so difficult that we really gave up. Instead, we tried icatibant with her. Icatibant did work, worked very well, but the next day she would show up in the emergency room again. We'd treat her, symptoms would get better. A week later, she would come in the emergency room, she would get icatibant. Again, the next day, she was in the emergency room so much. So, the thought process is here, what should we be doing for her? If she's IVs, very difficult. Icatibant is working. She has very large kind of adverse effects at the injection site, but it's really causing her to have like a stuttering appearance of her HAE attacks. So, the question would be, what would you want to do for this young lady? And so, we went through that. What would be really your kind of decision making? Which of the following factors would you consider important when determining if long-term prophylactic treatment should be initiated in addition to on-demand therapy? So would it be her family caregiver preference? Would it be the frequency and the severity of HAE attacks? Would it be the response to on-demand treatment? Would it be the side effects from on-demand treatment? Or would it be none of them? Okay, so I think the best answer here would actually be all the above, none of the above, that's for sure. So the factors I would consider is definitely her family and caregiver preference. That's very important, especially for children. The frequency and severity of attacks, right? The more attacks, the more need there is for prophylaxis, the more need there is to find a rescue medication available, the more need for having short-term prophylaxis as well. But everybody should have those latter two. The response to on-demand treatment, that's true too here. If you haven't access, that's difficult, and then you haven't medication that's not working. It's solving the issue in the emergency room today, but not preventing an attack the next day, then obviously you probably need prophylaxis. And then also side effects from the on-demand therapy. So what is the need for long-term prophylaxis? So we really have no criteria. And this young lady, we decided to use lanadelumab on her, and it's worked very well. In fact, now we haven't had her in the emergency room in the last 2 months, which has been fabulous for her. And hopefully next year in school, she'll do much better in school because she'll be attending school instead of staying home or being in the emergency room. As Marc mentioned, treatment should be discussed at every appointment. And it should be based on shared decision-making, whether or not prophylaxis is needed and which drug. You also want to look at the quality of life of the person, their treatment preferences, obviously, which is shared decision, attack frequency, any of the comorbid conditions, like if someone has arthritis, that might lead you to a pill instead of an injectable. And then their access to emergency care, right? Those people in remote areas probably need additional care than those who have good access. And then also, as I mentioned in this patient, the response to on-demand therapies. So with this woman, again, our treatment, we successfully treated her as we needed to with pre-surgery and pre-procedure C1 inhibitor. We could use that, but in most cases, we still think that icatibant would be the easiest drug to use in the emergency room because of her access. And we placed her on lanadelumab, and that's worked out very well. And that approval age is now down to 2. And then Marc will talk about the other prophylactic therapies, some which are also available in children. So with that, I think, Marc, I think now is your slide set starts. So thank you so much, Marc.
Yeah, thanks, Tim. Excellent background info. And thanks for the case. I like cases because I think it reminds us that there's always a person at the heart of these decisions, and that's why we're all here, to try to help our patients and families. So let's turn our attention to long-term prophylactic therapy for HAE. And as you've already heard a little bit, we have evidence-based guidelines. If we look at those evidence-based guidelines, and there's a number of them, there's a US guideline, an international guideline, a Canadian guideline. The good news is they're all quite consistent in their recommendations based on the scientific evidence. And so we have some recommended first-line options for long-term prophylactic treatment in HAE. Those are listed here as plasma-derived C1 inhibitor, lanadelumab, which is a monoclonal antibody against plasma kallikrein, and then berotralstat, which is an oral targeted kallikrein inhibitor. And you can see to the right there the pathophysiology that Tim went over, targeting these aspects of the kallikrein-kinin system. And one of the beautiful things about HAE, and I think one of the reasons we've seen such progress from the bench to the bedside, is that we understand this pathway pretty well for type 1 and type 2 HAE. So that's allowed drug development to targeted therapies to try to regulate this dysregulated pathway in C1 inhibitor deficiency. You also see there's some second-line options. These have been relegated to backups, if you will, in the evidence-based guidelines. Androgens, which were used for many years for prophylaxis, can be effective for patients, but more and more data accumulating about the adverse effects of androgens, both short-term, but mostly long-term, very serious side effects that are concerning. So the guidelines have moved away from androgens when we have other options available, and antifibrinolytics are not recommended, mostly because they're not as effective in type 1 and type 2 HAE. So efficacy concerns with drugs like tranexamic acid, now second line. And so here's a table of these first-line prophylactic options. I'm not going to belabor this, but it's important to be familiar with these drugs. Plasma-derived C1 inhibitor can be given either intravenously or subcutaneously for prophylaxis. Not surprisingly, we've moved much more towards subcutaneous administration due to both the ease, but also efficacy data suggesting that may be a more effective route. You see the age indication of 6 or older for the plasma-derived C1 inhibitor prophylaxis. Lanadelumab, which is a sub-Q monoclonal antibody targeting plasma kallikrein. As Tim just mentioned, this is now approved down to age 2 and above. So nice to have this option in the pediatric population. And you'll note there is specific dosing depending on the age group. And then finally, berotralstat, which is a once-daily oral plasma kallikrein inhibitor approved for 12 and above. Again, once daily taken with food. On the far right, of course, always important to be mindful of adverse effects. Any and all drugs have possible side effects. Long-term studies have shown that these are generally very safe without major serious side effect concerns, but we always have to counsel patients about not only rare serious issues, but the more common issues you see listed here and monitor for tolerability and side effects. So just very quickly so that you see some of the efficacy data, this is the COMPACT study, which was the plasma-derived C1 inhibitor product. You can see a phase 3 double-blind crossover study that looked at 2 different doses of sub-Q C1 inhibitor, 40 units per kilo in the top panels and 60 units per kilo on the bottom panels. Note that the 60 unit per kilo dose is the one that's approved by the FDA. And this was studied in type 1 and type 2 HAE patients. Here's the efficacy data, very impressive efficacy. You can see the mean reduction in monthly attacks was significantly reduced in the 60 unit per kilo dose, down from 4 attacks on average per month to less than 1 attack. And if you use this yardstick, which we'll kind of look at for these drugs of a 70% reduction in attacks or greater, you can see 83% of patients met that bar at the higher dose. Generally a very safe drug. Most of the events are mild in severity, and the biggest issue as a side effect was the injection site reactions with the sub-Q administration. This is lanadelumab, the pivotal trial, so-called HELP study. Again, phase 3 trial, double-blind, randomized. This is a parallel group study, and you can see 3 different doses of lanadelumab, 150 milligrams every 4 weeks, 300 milligrams every 4 weeks, or 300 milligrams every 2 weeks. And again, this was type 1 and type 2 patients compared to placebo for 26 weeks. And this efficacy data also shows very strong efficacy. So you can see here the reduction from placebo group at about 2 attacks mean per month down to, again, well less than 1 attack in the lanadelumab groups. Note that the FDA-approved dosing is the 300 milligrams every 2 weeks to start, with the option to transition patients to 300 milligrams every 4 weeks if they're well-controlled over a 6-month period. And we generally regard well-controlled as not having any attacks during those 6 months. Again, if you look at the 70% reduction in HAE attack rate or greater at that highest dose of 300 milligrams every 2 weeks, you can see it was 100%, and a little bit lower, 76% and 79% in the lower doses. Safety looked very good in this study. There were injection site reactions in 34% and a low rate of dizziness reported. Some anti-drug antibodies, although those have not been linked to a reduction in efficacy nor linked to any hypersensitivity reactions, so don't appear to be clinically important at this point in time. And then finally, the oral berotralstat study, the so-called APEX-2 study, phase 3 trial, again, parallel group. Here looking at 2 different doses, 150 milligrams a day or 110 milligrams a day compared to placebo. You can see the randomized portion was done for 24 weeks. Again, this study in type 1 and type 2 HAE patients. And you can look here, the efficacy here was a little bit less robust than the sub-Q drugs. The reduction, 2.35 monthly attacks in placebo down to 1.31 in 150 milligrams. So that's about a 44% reduction on average. However, if you look at the responder analysis, that 70% reduction or greater, 50% of the patients at the higher dose met that bar. And so this is a drug that works very well for some patients, perhaps a little less effective across the population. And again, if you look at this monthly HAE attack rate, you'll appreciate the baseline compared to the dosing, these significant reductions in attacks per month. Also, very reassuring safety data. There are some GI side effects to be aware of with berotralstat. These include some mild abdominal pain, diarrhea, vomiting. This usually improves over the first few weeks and patients become tolerant, but it's important to be aware of that and counsel patients that can occur. Rarely an issue that leads to discontinuation, but might be something that's bothersome to them for the first few weeks. All right, so with that, let's shift gears a little bit and talk about quality of life and unmet needs in HAE. And here's an interactive question. Which issues or topics are important to consider during follow-up visit in a person with HAE on a long-term prophylactic treatment? So is it adherence to recommended medication dosing, concerns related to adverse effects, effects of HAE on work, personal, family activities, review of attack frequency and severity, or all of the above? Yeah, so the majority of you are right on track. All of these things are important, of course. We want to make sure patients are able to adhere to the prescribed medicine. They're not having side effects. And ultimately, we want to know, is it improving their life? But also, is it preventing attacks? Tim, anything you want to add to the answer to this question?
No, this is exactly, and I think from talking to you in the past, Mark, both of us use little cards that tell people about, for the emergency rooms, especially to tell the emergency room doctors about what prophylaxis they have, about short-term prophylaxis, about acute attacks, and all these things really kind of go into that shared decision-making.
Yeah, exactly. So perfect segue to this topic of shared decision-making. And again, we've already talked about this a little bit, but I think it's important for us to think holistically when we talk to our HAE patients. This diagram on the right is a nice figure from a paper from Conrad Bork and colleagues. And it reminds us that, yes, these attacks that Tim talked about are very important. They're the prominent feature of the disease. So we should absolutely be asking about the location, the severity, the duration, the complications from these attacks. But we also have to recognize it's very clear now from studies that this is a condition that disrupts life even when people aren't having attacks. And that can be related to the anxiety and depression that's associated with this chronic condition, the unpredictability and the fear of when and where the next episode will occur. And as Tim already talked about, how this interferes with people's everyday life, their ability to socialize, to go to school, to participate in other activities. One thing I've learned over the years, if you ask the right questions, is that people really modify their life around HAE. They will not do things or avoid things or avoid certain situations that they're concerned will either complicate or be a major catastrophe for their HAE. So we have to realize this is not just about attacks, it's about the whole person and the impact on their life. And so that's where this conversation with shared decision-making comes in, considering all these factors, and then, as we've already mentioned, increasing use of long-term prophylaxis to try to just prevent these episodes from occurring rather than waiting for the disruption and the acute treatment that has to take place. So there are some ways we have now to measure quality of life and our success in treatment plans and how patients are affected. I won't belabor these, but be aware of the AQAL, which is a angioedema quality of life questionnaire. It's not specific to HAE, but it's been used in many HAE studies, and it asks about these different domains of functioning, fatigue, mood, fears, shame, and diet. And there's 17 questions. You see an example of a few of those on the right. Are you ashamed to go out into public? Are you tired because you're not sleeping well? Some things that we might not naturally think about, but that are part and parcel of this particular condition with recurrent swelling. There are other tools in development, and I'll just put in a plug that the US HAEA has just validated a US-specific HAE quality of life tool, was just accepted for publication. So you will probably see and hear about that in the coming months. Very important, takes into consideration some of our healthcare system issues, which include access to medication and how stressful it can be for patients to get medication and keep access to HAE medication, which not surprisingly affects their quality of life and stress that may actually worsen their condition. So that's, I think, a unique tool that may be useful to us in the future. And this is another one to be aware of, the angioedema control test. This is a 4-question tool, validated, and very important to be aware of. You can do this in clinic. Patients can fill it out before they see you. It asks these 4 questions about frequency, quality of life impairment, unpredictability, and whether the patient feels in control of the condition with their current treatment. And it has a cutoff score, which you can define as a person well-controlled or not well-controlled. Not a substitute for our conversation with the patient and that visit where we talk about how they're doing, but it does give you an objective measure over time to sort of see, is the plan that we've designed actually working well for the patient? And this is a good place for me to just point out these organizations, patient advocacy groups, the US HAEA and HAE International. We would not be where we are in terms of research, clinical care, new treatments without these groups who have really mobilized the patient population, encourage them to be involved in research, educational programs, a great resource for both healthcare professionals and patients and families. So if you have patients with HAE, please make sure they're at least aware of these organizations. It's a good place for them to tap in to the sense of community, but also learn a lot about hereditary angioedema to help us as clinicians have informed, educated patients. Thank you for joining us in this episode of Patient-Centered Approaches to Long-Term Prophylaxis in Hereditary Angioedema. Please return to the landing page to access the 3rd episode of this series.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.